Welcome to Knowing Your Way, a Princess Margaret ovarian cancer podcast. In previous episodes, we've discussed chemotherapy and surgery as important tools in the management of ovarian cancer. We've also discussed the importance of genetic testing as soon as possible in a woman's course of treatment. So I think we've developed a good base for our listeners who are interested in learning more about what we call maintenance therapy. Personally, I've been receiving maintenance therapy in the form of olaparib for some time now. I started it after I completed chemotherapy for recurrent cancer. I've got Dr. Taymaa May here with us as our expert guest to tell us a lot more about what is known about maintenance therapy. Dr. May is a gynecologic oncologist at the Princess Margaret Cancer Center and associate professor at the University of Toronto. Welcome, Dr. May, and thank you so much for joining us today.
Thank you so much, Alicia, for the invitation.
Well, you're very welcome. So, Dr. May, why don't we start by you telling us what is meant by maintenance therapy?
So maintenance therapy is a form of treatment that people benefit from after they've completed the therapeutic phase of their treatment. So for someone with advanced ovarian cancer, as you know, the most common treatment combination is a combination of surgery and chemotherapy. Once that therapeutic phase is finished, there is some data that maintenance therapy in the form of treatment that the person would take periodically, either daily or every several weeks for a period of time, would allow them to continue to have good quality of life and decrease the risk of recurrence of the cancer.
Okay. And can you tell us more about the appropriate candidates for various types of maintenance therapy?
So for the more common type of ovarian cancer, which we're talking about today, high-grade serous ovarian cancer, the other cancer would be high-grade endometrioid ovarian cancer, which is very similar to high-grade serous ovarian cancer. So for those epithelial cancers, studies have shown that there's two big categories of maintenance therapies that are very effective. One is PARP inhibitors, which you yourself have experienced. And that's a type of treatment that can benefit people with some mutations and also people with earlier stage disease, stage 3, for example. There's another treatment called bevacizumab, which is a treatment that can benefit people with more advanced cancers, stage 4, and people who have tumors that are not completely resected or who've never had surgery.
Okay, so I imagine that there are perhaps a larger number of people on the PARP inhibitors than the bevacizumab. Is that correct?
Yeah, that's correct. So PARP inhibitors are treatments that sort of came into common practice in the last few years. There have been a paradigm shift with the introduction of PARP inhibitors. There were two very large trials that have been sentinel clinical trials, have changed practice in ovarian cancer. One was SOLO-1 clinical trial, the other one's called PRIMA. And those two studies looked at two different agents, different drugs that are of the same family. One was called olaparib and the other one was called niraparib. And those two medications were studied in a little bit of a different cohort, but generally in individuals with stage 3 ovarian cancer who've had either surgery upfront, then chemo, or chemo first, then surgery. And they looked at different subgroups within those patients who've had different mutations. The most common one known is the BRCA mutation. And then they looked at people who've had what's called HRD mutations. So mutations similar to BRCA mutation, but slightly different. Nevertheless, they still have those mutations that can be targeted by the PARP inhibitor. And then the PRIMA study also looked at patients who have no mutations that are detectable. And in sort of as a general principle, the studies show that there is a benefit to taking the PARP inhibitor as opposed to the placebo. The majority of people with ovarian cancer have stage 3 disease, about 70%, and 10 to 15% would have stage 4. And by default, most would qualify for PARP inhibitor rather than bevacizumab.
Okay, all right. And the testing that is done early on in the woman's journey, does that capture not only the BRCA, but the other mutations
Mhm.
as well?
So there are many different types of tests that we can do. The common test that is being done on newly diagnosed tissue is BRCA somatic testing. So the cancer cells are tested for the presence of the BRCA mutation. Many labs and many pathology departments now have the opportunity and the capacity to do those tests, and those are very helpful. If the tumor expresses BRCA mutations, um, that can be targeted with olaparib or with niraparib. Those two PARP inhibitors have been shown effectiveness in that patient subgroup. They actually have the highest benefit to the PARP inhibitor as compared to patients who have a tumor that does not express this mutation.
Okay.
If there are other tests that are not widely available yet, they're not funded, there is a test called Myriad test. There's different companies that could do that. One of them is Myriad, that looks at HRD, so different mutations in addition to the BRCA mutation. I think it's important that those tests become available to everyone, but to date they are not, and they can be funded through different mechanisms, but not yet universally available.
Okay.
Mhm.
Um, so that you're referring to the tumor testing. So that's at
Mhm.
the time of surgery when tissues are removed from the surgical field, as we call it, and they're sent to the lab. And then there's also a simple blood, not a simple blood test, I guess. The drawing of the blood is pretty simple. The testing behind the technique that goes into trying to look for these mutations is complex, but very valuable. Can you expand on that a little bit?
Mhm. So yes, so there is the testing of the blood, as you said, and the testing of the tumor. And those are a little bit different. So sometimes people have what's called germline mutation, meaning that in the blood, they are inherently, the cells are inherently mutated. So the person has that mutation and they can pass it on to other members in their family, their children, for example, and that mutation is also expressed in the cancer. However, there are some people, the majority of people, who don't have any mutations in the blood. They don't have a germline change in their DNA, and they're not at risk of passing that mutation to their offspring, but the tumor itself has gone the mutation. So it's different mutations that could be expressed within the tumor versus within the blood of the individual. The genetic test that we would do on the blood itself would tell the person if they have a genetic mutation. We can test for BRCA mutation, and there's a panel that the genetic lab also can check for other types of mutations as well that could be increase the risk of ovarian cancer.
Okay,
Mhm.
thank you for summarizing that. We did have an episode on genetic testing for anyone that wants to learn more about that topic in particular. So back to the relevance with regards to treatment, I think you said that um, patients with specific mutations can benefit most from treatment, but you also reminded me before we started the podcast that it was a broader group of patients that may receive the drug than what I had thought. Can you
Mhm.
clarify that for me again and for the listeners?
Yeah, of course. So I think that's a very important distinction. And it's a very important time in ovarian cancer research. The last 10 years have been exciting from a scientific standpoint. We now understand the molecular biology of ovarian cancer a little bit more than we did before. There's, of course, a lot more research that needs to be done for us to truly understand the pathophysiology of the disease and how we can completely treat this cancer successfully and eradicate it. But we are making really big improvements these days. There's a lot of understanding of the molecular biology. And when we look at ovarian cancer, high-grade serous ovarian cancer, in general, we can sort of group it in three big categories. And this is sort of very crude, but the simplest way of looking at it is 50% of people would have what's called HRP, meaning the tumor is proficient, meaning it does not have a detectable mutation. It doesn't mean that there's no mutation, but the science we have to date, where the things we are testing for, that those tumors are negative for that. So those tumors are called HRP tumors, or non-mutated tumors. And that's about half of our patients. The other half have a tumor that is deficient, meaning it has a mutation that we recognize and we are testing for. Within that HRD family, the most famous or the most well-known in ovarian cancer is BRCA, or BRCA. And the BRCA mutated HRD tumors tend to be the most sensitive to PARP inhibitors.
Okay.
The second category in terms of sensitivity and benefit of PARP inhibitors is the HRD non-BRCA tumor. So they have a mutation, but in a different gene than the BRCA, different protein than the BRCA. And then the last group that benefits from PARP is the HRP mutated tumor.
Okay. So within the HRD, meaning a mutation with HR, and I don't think we need to go into what that means. The classic example is the BRCA mutation. And
Correct.
these women will benefit significantly from a PARP inhibitor. But then there are also women without the BRCA mutation who are in that HRD group that will also benefit. Is that correct?
Correct. So if you look at sort of statistics of, if you map out every person with advanced ovarian cancer in the high-grade serous category, 50% will have HRP tumor, 22% would have a BRCA mutated tumor, and 28% would have an HRD tumor, so a tumor that expresses a mutation, but it's a non-BRCA mutation.
Okay.
The SOLO-1 trial looked only at the BRCA mutated tumor. So either they had a germline blood mutation or they had a tumor mutation, and the response was similar. And they had a very good response to olaparib treatment as compared to patients who only received placebo. So they received a pill that didn't have an active ingredient. The HRD patients, so those 28% of patients who have a mutation, but it's not a BRCA mutation, it's a different type of mutation, they still benefit significantly compared to patients who had placebo. When you look at the overall benefit, it's less than patients who have a BRCA mutation, but it's still significantly better than getting no treatment at all.
Okay.
And the third category, and that was in the PRIMA study looking at niraparib, was the HRP patients. There was a modest benefit when patients were treated with niraparib, statistically significant in the progression-free survival. So there was a benefit to survival, decreased risk of recurrence, but it was modest and was less than patients who have a mutation.
Okay, thank you. Yeah, it can be complicated. I think if I wasn't hearing this if I was hearing this for the first time, I would want to rewind this part of the discussion in order to understand it. I think you've explained it very well, but for first-time listeners, it might be a lot of information. So you've talked about the data that supported the use then in all comers with advanced epithelial ovarian cancer, I believe. You talked about the benefit in the three groups. Can you be a little more specific about the degree of benefit, let's say in the women with the HRD, so that had mutations that were identifiable, in other words?
Yes, so that was, so patients who have non-BRCA mutations, but they are HRD, were included in the PRIMA trial, which is that study looking at niraparib. And that group of patients had a benefit. There's something called hazard ratio, meaning how much of a decreased risk of recurrence, and that was 50%, which was statistically significant. Their survival when taking the niraparib was doubled as compared to patients over doubled. So 8.6 months progression-free survival in patients who had placebo, and over 19 months survival, progression-free survival in patients who did not. So there was a significantly better outcome in that group of patients after taking niraparib. Now, it's important to remember, and those numbers might seem a little bit low,
Yes.
that patient population was high-risk population. So PRIMA study, as compared to SOLO-1 trial, was a study that looked at patients who had what's called high-risk disease. So by definition, it was patients who had tumor that were either inoperable at diagnosis, needed neoadjuvant chemotherapy, or had tumors that were suboptimally debulked.
Okay.
Now, for people, the majority of people, thankfully, have a tumor that can be operated, and once and if their surgeon takes them to the OR, oftentimes the outcome is optimal, and there's no or little residual disease, and those outcomes are significantly better.
Yeah.
So I want people to sort of take that in context. It's different groups of people, and really it's not about the number. Every person has their own trajectory. It's about the benefit of the combination of treatment and what works best for each individual person.
Okay, yeah. I myself, when I was initially diagnosed in 2015, I underwent surgery and then chemotherapy. Maintenance therapy in the form of a PARP inhibitor was not indicated or wasn't recommended at the time.
Mm-hmm.
I went on to have a recurrence in 2019 and received the traditional chemotherapy. And then, of course, I was a candidate. And I mention that because, to your point, we're all individuals. We'll all respond to the drug to some degree. And it doesn't have to reflect what we found in studies that weren't done, for example, in our institution with our physicians, with the specific care that we received in the past. And so, I'm grateful for that. And that is the perspective that I take, that sometimes I look at numbers and I think they don't look very good. They're disheartening to mull over, but your point of not necessarily trying to fit yourself in those statistics, but your own statistics, and maybe even your center statistics is more important. So thank you.
That is a very important point, and thank you for sharing and being so open about your own journey and your own experience. And I'm sure for you as a physician yourself, it is challenging for sure, because you understand the science and the data to a deep point and a deeper level. But it's a very important point that you made. Every person has individualized risk, and while we know molecular studies and we know 50% of people have that mutation profile and 22% have a different profile, every person has their own individual profile even within those. And there are definitely people who have much better outcomes, and people who may not have a very long outcome, but the key is to make sure that their treatment is effective, that we can treat the cancer successfully. It does not mean that we will never have to treat again, but it's something that we should always look at as a journey, and we can make it as healthy as possible, least side effects as possible, and that really is the key.
Right. Yeah. That's right. And so, but in general terms, we know that what you called progression-free survival, or just achieving more time with good quality of life between treatments of chemotherapy, for the most part, that's super important. But you mentioned side effect profile of the PARP inhibitors. Can you expand on them, please?
So there are, PARP inhibitors, the two most common ones that are used and the two that are approved to date in Canada are olaparib and niraparib. And those are, olaparib is Lynparza and niraparib is Zejula. Those are the sort of commercial names. The most common side effects tend to relate to GI toxicity. So sometimes nausea, rarely vomiting, but sometimes they can cause decreased appetite. They can cause changes to bowel function, diarrhea, sometimes constipation. They can cause fatigue, and I often recommend to my patients take it at nighttime, so they can go to sleep after, and they usually wake up in the morning feeling better.
That
They
would be
can,
patients on niraparib, presumably, because that would be the once daily medication.
correct, yeah,
This is the olaparib, which I'm on, for example, that's twice a day. Yeah.
it is twice a day, yeah, yeah.
Okay.
The other side effects are blood test related, so hematological side effects. The biggest one is platelets changes. So sometimes they can cause what's called thrombocytopenia, meaning decreased level of platelets. They can cause anemia and rarely some rare tumors of the blood system. They can cause white blood decrease. And the last thing is kidney changes. Sometimes we do see that as well.
Okay.
But
So,
overall, they are reasonably well tolerated as compared to chemotherapy. They're really well tolerated that way.
yeah, yeah. And I can add from my personal experience that I do have fatigue. I think that that would be my biggest side effect. It was noticeable when I started the PARP inhibitor, but it's manageable. So I do most of my activities in the beginning of the day. I rest in the afternoon, and then, I might be a little more active in terms of cooking dinner or whatever in the evening, but fatigue is there, but as I say, manageable. And then with regards to the different effects, the potential effects on the different types of blood cells, it sounds like you covered most of the types of blood cells, or all the types of the blood cells that the human body produces. But at the clinic, we're followed very, very closely in order to monitor for those effects on the blood cells. I go every 3 months. I think it's possible that others may go different intervals. But I know it's something that Dr. Bernardini has a very close eye on.
Yes, so it's definitely an important measure. We have to monitor patients, especially when they start the treatment, very closely. So when we start PARP inhibitors, we usually will see the person every week for a month, check their blood tests. Niraparib can also cause hypertension, so high blood pressure. So we would be checking their vital signs, making sure they're tolerating the medication okay. So usually we'll see people weekly for a month, then every 2 weeks for the second month, and after that, monthly. After a year, there is a possibility of extending that interval more than a month. The most common period of side effects, according to the 2 main trial, was in the first 4 weeks. So once you get past the first month, statistically at least, there was no difference between the placebo group and the treatment group. So most of the side effects sort of stabilized after the first period.
Okay. Thanks. There's always that feeling of security that somebody's watching out for those things, because it's true that many patients, regardless of what kind of patient they are, what kind of drug there are, many side effects can go undetected in terms of how you feel yourself as a patient. So we've got the support of a very well-structured clinic that's guiding us in that way. Yeah. Now, I've been having a conversation with Dr. Bernardini about duration of the treatment. I spoke to him just about 45 minutes ago, and we were talking about when to stop the drug. Can I get your view on that? And, I am taking advantage of this opportunity for myself, but I think listeners, just if you could provide some general thoughts on the situation. You don't have to give me another consult, as I've spoken to Dr. Bernardini about it.
Yeah, it's an excellent question, and I'll tell you my opinion based on the science, and I would love to hear your perspective from your perspective, because I do hear sort of both sides from my patients. So basically, Solo 1, which was the study looking at olaparib in patients with BRCA mutations,
Yes.
was a study where people were treated for 2 years. And after 2 years, there was a sustained benefit to survival. So there was an updated analysis at 5 years and another updated analysis at 7 years, and the results are excellent. In a group of patients that had primary surgery, have what's called, stage 3 disease, but low risk disease, the 5-year survival, recurrence-free survival was 56%.
Sorry, Dr. May, can you repeat what you said about that group of patients? They had stage 3 disease and...
So patients who had stage 3 disease, had primary surgery, had optimal cytoreduction. So basically patients who have what's called favorable disease. So they had operable disease at diagnosis, had optimal cytoreduction, and they have stage 3 as opposed to stage 4.
Okay, so cytoreduction meaning it doesn't appear that there's any tumor left behind at the time of the surgery?
Exactly. So at the time of surgery, there's either no tumor or microscopic tumor, which in most practices, this is the standard for any ovarian cancer surgery, is not to have any disease remaining at the end of surgery, because we know survival is positively linked to the surgical outcome. So if the surgical outcome is complete or optimal, there's an increased benefit to survival. So in that group of patients who have a BRCA mutation were treated with olaparib for 2 years.
Yes.
56% of those patients had not recurred.
At
This
5
is
years time.
This is a big statement. This is a big number, 56%. That tells us the majority of our patients have not recurred after 5 years. These are numbers where people start to talk about a cure.
Yes.
This is a rare word in ovarian cancer, but it's such a lovely word, and it's sort of, we're cautiously starting to think of it. There is a subcategory, there is a group of patients where when we know the proper mutation and we know the proper treatment for that mutation, we can eliminate a tumor, and that's the goal.
Yeah, yeah.
So, and the reason I bring that is those patients were treated with olaparib for 2 years, and they were off treatment for 3 years, and they still had the exact same benefit. The survival curve did not change. So I think it's important to be treatment-free, disease-free for such a long period of time. We are talking here about a group of patients who hopefully will never recur, or if they recur, they'll recur at a very, very late time where we can salvage again, treat successfully again, and put the cancer in remission again. And we want the person to be fit and strong and healthy, and not to have 3 additional years of medications that they don't necessarily need, side effects that they don't necessarily need. The longer you're treated with something, the more side effects you have. There are rare tumors, blood sort of cancers that can develop the longer you are on treatment.
Yeah. So
I believe that you should be on treatment for the maximum amount of time where it's beneficial, and you come off of it as soon as you don't need it. Yeah. And for olaparib, it's 2 years. For niraparib, it's 3 years.
Yeah, yeah. Yeah, so that sounds like the rationale that's been discussed with Dr. Bernardini, that, since the drug's effect is it is a very positive one, that to expose someone to even a very small risk of what could be a serious side effect, like the problems that can affect the bone marrow, would be a huge shame, like a real shame to. And then not only that, as I discussed this afternoon with Dr. Bernardini, my main side effect has been the fatigue. And so he's actually recommended that I stop the drug for at least a month to see how it affects my fatigue. And I look forward to seeing if I will have more energy, because that's the one thing that's bothered me about the drug. As I said, manageable, but and so then we'll take it from there.
That sounds like a very reasonable approach.
Okay.
And how do you feel thinking that you might come off of the PARP inhibitor?
Yeah, so it's funny because, as you mentioned, I'm a physician. I read studies. I understand data. I understand the logic, but I have looked at the olaparib as a bit of a security blanket. over the years. And therefore, I do emotionally feel anxious about it. I do.
Yeah.
And so
I,
I know you can't reconcile the logic with the emotional part, but we're human beings, I guess. And that's the way I feel. Yeah.
yeah, I think that's a very real issue, and a lot of people feel that. It is, and it's totally understandable. It is understandable. There is this feeling that if I'm on it, it's going to prevent something, and if I come off it, potentially the cancer will come back. But the science does not show that, and I think the more recent publication in the Lancet of the long-term outcome of Solo 1 at 5 years was very reassuring, and I think that sort of allowed a lot of us to sort of breathe out a little bit and feel that it is safe to come off after 2 years once we've maximized the benefit of this medication.
Okay, great. Good. And for listeners that have not yet started the medication, how is it paid for? It's very expensive. I know that much. So what are the various sources of payment?
So in Ontario, it is funded. For olaparib, it's funded for people with a BRCA mutation, either a germline or a somatic mutation. Niraparib is funded for any individual with advanced, so stage 3, or for high-grade serous ovarian cancer, or high-grade endometrioid ovarian cancer. It's a mechanism where the physician has to put in an application for medication reimbursement, and every institution would have those sort of mechanisms through pharmacy, and we would submit an application to Ontario Health, to Cancer Care Ontario. They might ask for pathology reports just to confirm the diagnosis and the mutation, and it shouldn't be an issue. It just takes a little bit of time to get that. So usually the process is done before the patient finishes chemotherapy. The drug often starts between 4 and 8 weeks of the last chemotherapy.
Okay, yeah. The pharmacy at Princess Margaret was obviously instrumental in getting things going. And in my situation, they worked with my insurance company and made sure all the paperwork was in order. So it was fairly straightforward for me.
Yes, yeah. We had a period of time where we didn't have ministry funding, and we had compassionate funding from the pharmaceutical companies, which allowed us to bridge that gap. Because once the clinical data came out, it took a while for us to sort of have that go through the proper channel, through the Ministry of Health, to have that approved as an indication. And so that was a very helpful bridge. For now, I think every person should have access to funding. Every person who qualifies, either through their private insurance or through the ministry. The timing is important, so that conversation usually starts before we finish chemotherapy, so we can put in the paperwork.
Right. Okay. Is there anything else that you'd like to discuss with regards to the PARP inhibitors before we move on to the drug called bevacizumab?
I think one of the advantages of PARP inhibitors is they come in pill form. They are targeted therapies, so they go sort of beyond chemotherapy. Targeted therapies as a family of therapies target mutations within the tumor, so they tend to have less side effects than chemotherapy, which usually targets general cell mechanisms, replication, or fast dividing cells. So they tend to be well tolerated. One of the best advantages of PARP inhibitors is that they are pills and they can be taken at home. A lot of patients are traveling and they take them with them, so they're not necessarily having to come back to the cancer center for infusion if they are on intravenous medication. And I found that to be really liberating for people, even though we have to do blood tests. You know, a lot of our patients travel to Florida for the winter, or they go to Europe, and we can do blood tests through their physicians, you know, in their travel in their country there, and they can make sure that things are good, and they can come back after a period of time. So that has been a very, very friendly, user-friendly treatment.
Yeah, I would agree with that for sure. Okay, and so earlier we were talking about another drug called bevacizumab. Can you tell us in which patient groups you think bevacizumab would be an option?
So bevacizumab is a different type of targeted therapy. So it's what's called angiogenic inhibitor. So it's basically, as a general, it works on blood vessels formations within within the cancer cells. It is a drug that can be effective in people with high risk ovarian cancer. So in Ontario, it is approved for patients with stage 4 ovarian cancer, with patients who never had surgery, or patients who had surgery, but the outcome was what we call suboptimal, meaning that there's at least a centimeter of tumor behind.
Okay.
In those individuals, the studies show that there is a benefit to treating with bevacizumab, and we would overlap bevacizumab with chemotherapy for at least 2 cycles, then treat with maintenance bevacizumab, and that would be an infusion. So it's an IV medication that people would get every 3 weeks for a total of 12 cycles. So it's just under a year of treatment.
Okay. 1 year and every 3 weeks. So the patient would go to, is it the same chemo clinic that is used for the traditional chemotherapy?
Yeah, it is the same chemo suite. At Princess Margaret, it's on the 4th floor. It's the chemo unit. Patients come every 3 weeks. They need to have the regular chemo blood work. In addition, they also have to have a urine test. Bevacizumab can cause high blood pressure. And one of the early signs of that is proteins in the urine. So we see people every 3 weeks. We check their blood work, we check the urine test, we check their vital signs, we see how they're feeling, and if they're doing well, then we usually do the treatment a day or 2 after that.
Okay, great. And at the top, you talked about bevacizumab being a drug that affects the blood vessel formation within the tumor, which is, it's so interesting to, to think about that, what we call mechanism of action versus traditional chemotherapy, where rapidly dividing cells are impacted. So it includes not only the cancer cells and the patient's own cells lining the gut, for example, causing diarrhea. And then also the PARP inhibitors, where the drug prevents the cancer cell from repairing itself. And to that end, too, I think there are other mechanisms of action that are being investigated by our scientists in order to come up with alternate treatments as well. I don't know that they're readily available now, but is there anything in the pipeline that you find promising?
So there are sort of a lot of mechanisms that are being studied. One of the also avenues that are being looked at is combining medications. So there was a study looking at combination of bevacizumab with a PARP inhibitor. There was a study called the BAULA trial that looked at olaparib in addition to bevacizumab. So in combining these medications, there was a benefit to the combination arm. But there are other studies looking at olaparib alone as compared to the combination. So it would be interesting to see that down the road of how many combination therapies are necessary and what's the minimum amount of treatment that we need to get the maximum benefit. One of the most famous targeted therapies is immune therapy. To date, there are a few studies, but there isn't one that has shown benefit in the maintenance phase yet in ovarian cancer.
Okay, thank you. Two thoughts come to mind. One is you're talking about combination therapy, and for our listeners, most listeners will have taken an antibiotic in the past, and usually you take one antibiotic at the time, but in some scenarios, infectious diseases physicians like myself will give 2, 3, or 4 drugs, and we call that combination therapy. And each of those drugs, as Dr. May was saying, targets a different mechanism by which a cancer cell can continue to grow, and that improves the chances of killing the cancer cell. So similarly with ovarian cancer, this is something that's being looked at. In my other discussion with Dr. Bernardini earlier today, I was also sharing with him that it would be nice if one day we could assess the cancer cells' resistance to various treatments right up front, right at the beginning of treatment, or along the way, if at all possible. And maybe that will be something that will also come down in the scientific research pipeline.
I agree 100%. I think there's a lot of opportunities for the future. There's a lot of research that we can do to understand the mechanism of action of every cancer. A lot of what we do now is retrospective. So we treat with something, the person developed resistance, and then we say, okay, this was resistant to that. It would be better if we can predict that this will be resistant, and then we wouldn't use the drug that is not going to be effective, and we use something that is more effective. There are scores that are being developed. One of them, for example, is called the Kellam score, where we use the change in CA-125 in patients with neoadjuvant chemotherapy, and we see how that score reflects correlation with resistance or sensitivity to chemotherapy.
Right.
So we actually, our group just published on that this month, looking at those predictors of sensitivity to chemotherapy. There's a lot of things that are being done that hopefully will help us continue to personalize treatment. I think that's the key, is to make sure that we understand individual tumors and then tailor the treatment for every person to maximize the benefit that they need from each of the available treatments.
Yeah, that's great. Yes, that sounds familiar, what you're talking about with that specific study using the CA-125, not only just the CA-125, but the rate of change of the CA-125 and what that might mean for patients' response to treatment. It also reminds me that there's a lot of really good research going on, not only at Princess Margaret, but everywhere. And it makes me very, very hopeful. Of course, as I mentioned earlier, this drug was not available to me when I was initially diagnosed, although it became available later. And so it offers substantial hope to me and to many other women, and to the clinicians that are dedicating their lives to improving the state of management of ovarian cancer.
Yeah, I agree with you. I am hopeful as well. I think there's a lot of opportunities, and within our ovarian program at Princess Margaret, we can do our best to really understand the disease distribution, the person's functional status, their tumor biology, the molecular profile that tumor expresses, and with that come with hopefully a tailored, personalized treatment approach to every person with ovarian cancer. And with that, try to maximize the benefit of all the available treatments to date, while at the same time we continue to do research, continue to improve outcomes moving forward.
Well said, very well said. Thank you for summarizing that. If there's anything else you'd like to add to the conversation, Dr. May, I'd be happy to give you my ear and our listeners' ear.
I think, well, I would like to thank you, Alicia, for putting this on. I think it's a very important podcast, and it's, I'm sure, very comforting for a lot of people to hear that from someone who has medical background and also is going and has gone through treatment. So I'm very appreciative that you're doing that. And the last thing I would encourage everyone is to ask questions. That's why we're here. Myself as a physician, our nursing navigator, our team members, our scientists, everybody's here to try to do their best to really understand the science and give the best option for every person. So I would encourage every person to ask questions to their physicians and see what works best, and the timing of treatment is really a discussion and understanding when it's best for you. That would be very helpful.
Okay, great. Thank you. Thank you once again. And for your favorable comments regarding the podcast. Not only am I grateful to have you as our expert guest and others in the past, but also Tara Almasi, previous program coordinator of the program at Princess Margaret. And today we had Steve from Technical Services helping us out. So thank you, and enjoy the rest of your day.